Uh, Good afternoon, all. So I'll be discussing about our research work on low frequency T790M detection in lung cancer using NGS. So as we all would be aware that EGFR mutation testing is a routine practice for lung adenocarcinoma patients, and patients which have EGFR sensitizing mutations like mutations in exon 18, 19 or exon 21 are routinely treated with gefitinib and erlotinib, which are the first generation inhibitors. And we also know from a number of clinical trials carried out abroad as well as in India, in Tata Memorial Hospital, that the EGFR mutation positive patients treated with this first generation inhibitors have a significantly higher progression-free survival compared to those patients if the patient is treated with chemotherapy. However, majority of these patients, like more than 80% of the patients, they develop resistance to this first generation EGFR inhibitor treatments. Now, why do these patients resist? Is the primary reason for this is because of the secondary mutation in EGFR, which is the T790M mutation, which is known to occur in 50% of the cases. And we also are aware that for these patients who acquire T790M mutation, the standard of care treatment is osimertinib, which is the third generation inhibitor, as is also proven by a number of clinical trials. And thus, for patients who resist this first-line EGFR tyrosine kinase therapy, first-generation therapy, or the EGFR T790M mutation testing is a routine practice, and usually real-time based PCR is used for this diagnosis. Now, recently there have been papers where they say that there is a association between the allele fraction of T790M and the osimertinib response. What they say is that low allele fraction of EGFR T790M, it is associated with a poor response to osimertinib. However, all of these studies are actually on the like you say, the liquid biopsies, and the clinical utility of osimertinib to low allele fraction T790M in tissue biopsies is yet to be explored. Thus, we raised the question whether osimertinib can benefit patients with resistant tumors harboring low allele fraction T790M mutations. Now, to address this, what we did is we longitudinally collected biopsies from lung cancer patients who were EGFR mutation positive, and they responded to the treatment. Then they resisted this treatment and eventually showed resistance to this treatment. However, what we set a criteria that this resistant tumors, it should be negative for T790M based on real-time PCR. So this is how we collected the samples, and we performed a whole exome sequencing on it. And then we detected whether we can see if there are any low allele fraction EGFR T790M mutations that can be detected. And indeed, if you can see, what we observed is that in 4 out of 16 patients, the EGFR T790M mutation, which was missed by the conventional real-time PCR, was actually detected at a low allele frequency. When we checked the reads and in the IGV screenshot, we could see that there were all of these were at a very low allele fraction of 5 to 6% in 4 of 16 patients. That means 25% of the patients were actually false negative based on conventional real-time based PCR. Next, we wanted to model this in the laboratory settings, and for this, what we did is we took PC9 cells. So PC9 cells are lung cancer cells which have EGFR exon 19 deletion, and we treated it with erlotinib until we could see clones which could resist this treatment. So we termed it the PC9R cells. And if you see the drug response curve, this blue one is the PC9 and red one is the PC9R. So we could clearly see that PC9R was resistant to erlotinib. And to ensure that both of these cells are actually from the sensitive cells, we did an STR profiling, and we confirmed that PC9 and PC9R were actually identical. Next, what we did is we performed a Sanger sequencing to check the status of EGFR T790M in this PC9R cells, the resistant cells which we were developed, and we could actually see that there was no T790M. That is, based on Sanger sequencing, we did not detect T790M in the resistant cells, the PC9R cells. However, when we did an NGS on this, we could actually see that this, while the PC9 cells, they did not have a T790M, but PC9R cells, they had acquired T790M at a lower allele fraction of 5%. So which was actually the case when in our patient samples as well, wherein initially those which were missed by the conventional T790M detection, which was missed by the conventional PCR-based techniques, was actually detected by NGS, and similarly we observed it in the cell lines. Next, we confirmed this. We validated this T790M mutation using an allele-specific PCR, wherein what happens is we design primers such that only the mutation, if the mutation is present, we see an amplification. And if you can see the PC9 cells, there was only amplification following the wild type specific primers, and there was no amplification following mutant specific primers. However, for PC9R cells, we could clearly see an amplification based on mutant as well as the wild type specific primers, confirming the presence of T790M in PC9R cells. Now this T790M, we wanted to confirm what could be the biological basis for that. So there could be two reasons. One could, there is, as we all know, that there is a tumor heterogeneity which is in place. So is the T790M low allele fraction because of the tumor heterogeneity, or is there an amplification of the wild type allele at the EGFR loci, because of which this low allele fraction is detected? So for that, what we did is we took this PC9R cells and we sorted them, and individually we grew about 20 colonies. And in those 20 colonies, we again did a allele specific PCR to confirm whether T790M is present. And actually what we observed is in all of these 20 clones, we could see that T790M was present at a low allele fraction, which was detectable only by allele specific PCR and not by Sanger sequencing. Thus, we concluded that this PC9R cells acquired EGFR T790M at a low allele fraction of 5%. Next, we went on to check whether osimertinib is actually active on this low allele fraction harboring PC9R cells. So, and we could see in vitro that this both PC9 and PC9R cells, so PC9R cells with a lower allele fraction of T790M, they were equally responsive to osimertinib and the in vitro conditions. Then what we did is we took the cells, and as was described in the earlier presentations, we tagged them with luciferase to monitor the, so that we can monitor it in the mice. And we injected these cells into orthotopically into the lungs of mice. And we followed whether this mice, even in the in vivo settings, whether this osimertinib response is seen. And we actually concluded that this is the, so before that we checked whether our model is well established, and we confirmed that we could see the clinical signs and symptoms of lung cancer in this the mice which were injected with this PC9 cells, like pleural effusion. We could see locoregional metastasis to the other lobes of lungs, and this tumor formation was confirmed using H&E staining. And then we checked whether this PC9 and PC9R cells, we injected them into mice to check the response of the drugs on the EGFR TKIs on this mice. And we saw that in case of erlotinib, only PC9 was responsive. The tumors, obtained from the PC9 cells, and in PC9R cells, the tumors were resistant to erlotinib treatment. However, as was seen in vitro, we saw that even the in vivo tumors, they responded to osimertinib, but they were resistant to erlotinib. And in osimertinib, both PC9 and PC9R cells were equally responsive. Thus, to conclude, so we observed that 25% of the patients are actually, they are missed by the T790M status in 25% of the patients is called to be false negative by real-time PCR, and in a way they are not given osimertinib because their report is negative. And hence we again would like to put emphasis on the fact that NGS needs to be done on at least on those patients who are who are negative based on real-time PCR, to confirm whether they have this T790M at low allele fraction, and this osimertinib treatment, which is a standard treatment, it can still be applied to low allele fraction EGFR T790M patients, and thus we in a way extend the benefit of osimertinib to a larger group of patients. So I would like to thank my team, and thank you to Anuradha ma'am for inviting me. Thank you. Yes.
Sacrifice the mice eventually due to autopsy.
Yes.
Have you analyzed the T790M mutation in those outgrown tumors post osimertinib?
So post osimertinib, sir, we did not see any outgrowing tumors.
So day 56, there was a tumor in PCR9.
That was for
no, that was osimertinib day 56.
So sir, that was I mean that those are some residual cells which are getting picked up. So as such, tumor was not there. Okay. So we could not isolate the tumor. So when we sacrificed it, the lungs did not show any tumor.
Okay. Thank you.
Thank you.